Your doctor told you that you have osteoporosis. They showed you a DEXA scan report with a number on it. They wrote a prescription. You took the medicine every week or once a year in a drip. And then one morning, you slipped in the bathroom and the bone broke anyway. How can this be? How you did everything you were told to do? I want to explain to you in the next 15 minutes why this happens to so many people and why for some of you the bone broke not because the medicine failed but because the medicine was designed for one cause and your bone loss had a different cause. உங்க எலும்பு உங்களோட கதையை சொல்லுது. நான் கேட்கணும். Let me start with something most people are never told. Bone is not stone. Bone is a living, breathing tissue. Every single day in every adult human being, bone is being broken down and rebuilt. At the same time, in the same skeleton, there are two cells doing this work. One is called the osteoclast. It chews bone away. The other is called the osteoblast. It lays new bone down. In a healthy adult, the two are in balance. The osteoclast takes away the old weakened bone. The osteoblast replaces it with new strong bone. The skeleton stays the same intensity year after year. Osteoporosis is what happens when that balance breaks. But here is a question almost no one asks. Did the bone removing cells start working too fast or did the bone building cells slow down? Because those are two completely different problems. And they need two completely different answers. The medicine your doctor wrote you a prescription for, most commonly a bisphosphonate, sometimes denosumab, has one job. It slows down the osteoclasts. It puts a brake on the cell that chews bone away.
It puts a brake on the cells.
That is what it does. That is the only thing it does. And when the problem in your bone is too much resorption, the osteoclast working overtime, that medicine can help. The classic case is the woman in the first 3 to 5 years after menopause. When estrogen falls, the osteoclasts are unbridled. The brake comes off. Bone is removed faster than it can be replaced. For that woman, in that window, a bisphosphonate is a rational choice. But here is the part no one tells you. Not every osteoporosis is a runaway osteoclast problem. For many patients, perhaps most patients over the age of 70, the osteoclasts are not the problem. The problem is that the osteoblasts have stopped building. The construction crew has gone home. And if you put a brake on a crew that has already left the site, nothing is going to be built. The medicine cannot help because the medicine was not designed for that problem. Let me walk you through the 6 things that drive bone loss in a human skeleton. These do not compete with each other. They stack. Most patients I see have 2, 3, sometimes 4 of these operating at once. 1. Estrogen deficiency. The post-menopausal collapse. This is the cause bisphosphonate partially addresses. If a woman is in the first 5 years after menopause and her bone density is dropping fast, the resorption-driven model fits and the bisphosphonate is a defensible choice for that window. But estrogen deficiency is only one of 6 and after the first 5 years, the pattern usually changes. 2. Vitamin D deficiency. Without adequate vitamin D, the gut cannot absorb the calcium you eat. The bone cannot mineralize properly. You can take 1,000 milligrams of calcium a day and put none of it into your skeleton. In Chennai, in this climate, with our indoor lives, vitamin D deficiency is the rule, not the exception. We check it on every patient. The number on the report tells us whether the building blocks are even available. 3. Inadequate protein intake. Amma, நீங்க சாப்பிட்ற புரோட்டீனே போதாது. Bone is not just calcium. Bone is a protein scaffold, collagen with calcium laid on top of it. No scaffold, no place for the calcium to go. The Indian post-menopausal woman in the household I see every day is often eating 800 calories of rice and vegetables and almost no protein. She is told to drink milk. She is told to take calcium tablets. No one tells her that her bones cannot be rebuilt without 1 gram of protein per kilogram of body weight every single day. You cannot build a brick wall without bricks. Calcium is the mortar, protein is the brick. 4. Mechanical under-stimulation. This is the cause almost no doctor talks about, and it is one of the largest. Bone is built by load. The osteoblast, the building cell, only switches on when it senses force passing through the skeleton. If you do not load your bones, your osteoblasts do not build. It is that simple. This is where I want to introduce you to a piece of research that changed how I think about this. It is called the LIFTMOR trial. Watson and colleagues published 2018. Post-menopausal women with low bone density were put through a structured, supervised program of heavy resistance training and high impact loading twice a week, 8 months. The result: bone density improved at the spine and at the hip, significantly more than in a control group, doing only gentle low intensity exercise in women who are already osteoporotic without any medicine, just appropriate supervised load.
If the cause is mechanical under-stimulation, then controlled loading is the best solution.
The bone responded because the bone was asked to. The pill cannot ask the bone anything. I do not say this to tell you to throw your medicine away. I say it to tell you that the osteoblast in your skeleton is waiting for a signal that in a sedentary life it never receives. 5. Metabolic dysfunction. This is the cause hiding in plain sight in our clinic, in our city, in this country. High blood sugar, high triglycerides, low-grade systemic inflammation. The diabetic patient has impaired bone formation independent of a DEXA score, a low turnover state where the density number can look reassuring when the bone is quietly weaker. The same insulin-resistant biology underlies metabolic syndrome. The high triglycerides, the inflammation, and the bone is increasingly thought to suffer in the same way, though that link is still being pinned down. If you followed this channel, you know we measure 4 markers on every patient: HbA1c, triglycerides, vitamin D, and high sensitivity CRP. We weigh HbA1c at 50%. The same panel that tells us whether your knee can heal tells us whether your bone can build. 6. The secondary causes: long-term steroid use, hyperparathyroidism, untreated thyroid disease, heavy alcohol, heavy smoking, certain anti-epileptic drugs, certain proton pump inhibitors used for many years. Each of these has a specific mechanism. Each is correctable in its own way. So there it is. 6 causes, stacked, not competing. Now look back at the medicine. The bisphosphonate addressed one of these and only partially. It does not give you vitamin D, it does not give you protein, it does not load your bones, it does not lower your HbA1c, it does not stop the steroids you are taking for something else. And that is why for so many patients, the medicine alone is not enough. I want to be careful here. I'm not telling you to stop your medicine. If your doctor has prescribed a bisphosphonate or denosumab, that decision belongs between you and your doctor. But you are entitled to know what the medicine does and what it does not do. 2 things briefly. The first is called atypical femoral fracture. After many years of bisphosphonate use, in a small number of patients, the bone in the thigh becomes brittle in an unusual way. It can crack with very little force. The mechanism is suppressed remodeling. The bone cannot repair its own micro damage because the osteoclasts have been turned down too far for too long. This is rare, but it is real. And it is the reason that long-term bisphosphonate use is now reviewed at the 5-year mark in most international guidelines. The second is denosumab rebound. If denosumab is stopped without a planned transition, bone loss can accelerate, sometimes faster than before the medicine was started. This is well documented. It is the reason a patient on denosumab needs a plan for what happens next, not just a prescription. A medicine that needs a plan for stopping is not a medicine you can take and forget. I mention these not to frighten you. I mention them because they are part of the honest accounting. Now, I want to bring this back to the work we do at the Madras Joint Rejuvenation Centre. எலும்பும் மூட்டும் ஒன்னோடு ஒன்று சேர்ந்த கதை. 2 weeks ago, I made a video on this channel called Two Stories, One Diagnosis about how the bone and the joint are not two separate organs but one continuous structure telling the same metabolic story. If you have not seen it, watch it after this one. It is linked below. I will not repeat that whole argument here. I will only take the one piece of it that matters for today. If the bone and the joint are one same story, then the same tools that read the joint will read the bone. On the 12th of April, I described the Prasad orthobiologic treatment, the biological treatment we use for the arthritic knee. The diagnostic spine of that protocol is the 4-marker panel I mentioned earlier: HbA1c, triglycerides, vitamin D, high sensitivity CRP. We use that exact same panel to triage the bone. Because if your metabolic environment is hostile, neither the cartilage nor the bone can heal. And no injection, no surgery, no pill can overcome a hostile internal environment. You cannot rejuvenate a tissue when the soil it lives in is poisoned. The work then is the same in both cases. Find the actual cause, correct the metabolic environment, then and only then intervene biologically. So, what does this mean for you, the patient who is watching this? It does not mean you should stop your medicine. It does not mean you should throw the DEXA scan away. It means you should ask one question of whoever is treating you: which of the 6 causes is operating in my bones? And how do you know? If the answer is we don't know, but the pill works for most people, that is not enough. You deserve to know. The proportionate strategy when we work with the patient who comes to us with bone loss looks like this. We measure the 4 markers. We had a parathyroid hormone estimation, a vitamin D, a TSH. In selected patients, a 24-hour urinary calcium. We examine the diet, really examine it, not glance at it. We look at the mechanical history. We look at the medication list. Then we make a plan that matches the causes we find. If the cause is vitamin D deficiency, we replace it properly to a target level. If the cause is inadequate protein, we work with the patient and her family to change what is on her plate. If the cause is mechanical under-stimulation, we refer her into a supervised progressive resistance program. Not a yoga class, not a daily walk, a structured load program of the LIFTMOR kind scaled to her starting point. If the cause is metabolic, we treat the HbA1c, we treat the triglycerides, we treat the inflammation. If the cause is genuinely an unbridled osteoclast problem in a recently post-menopausal woman, yes, the bisphosphonate has a place. And if there are multiple causes stacking, which is the usual case, we address them in parallel. The strategy fits the cause. The cause is found first. The pill is one tool, not the whole toolbox. I started this video with a patient. She took the medicine every week for years. She fell. The bone broke. She is not one person. She is a pattern I see again and again. And what I did not tell you at the beginning is what we find when patients like her come to us after the fracture. Again and again, the same picture. A vitamin D far too low, a protein intake of barely 30 grams a day, a body that has not truly loaded a bone in years, the HbA1c quietly creeping upward. They were being treated for the one cause they did not have. They were not being treated for the 4 causes that were emptying the skeleton. The pill did its job. The job was just the wrong job. She is not unusual. She is the rule. அம்மா, உங்க எலும்பு உங்களோட கதையை சொல்லுது. நாம் இன்னும் கேட்கல. If this video has been useful, share it with the person you are thinking of while you watch. That is how this channel grows. Not through algorithms, through one human being telling another that there is a better way. If you have a parent or someone you love whose story sounds like the one I described at the start, and you want to know whether their osteoporosis has a cause that is being missed, write to us. The clinic details are in the description below. I am Dr. A.K. Venkatachalam. This is the Madras Joint Rejuvenation Centre. This is how we think about bones.